So my lecture is going to be a deep dive into pediatric sickle cell emergencies. I think it's a pretty pertinent topic, especially in our patient population. It's very important to be able to recognize the different types of pediatric sickle cell crises, things that they can present with, as these patients can decompensate and become sick very quickly. So objectives are, we're just going to do a quick overview of sickle cell disease, and then hopefully by the end of this you'll be able to identify life-threatening pediatric sickle cell emergencies and know a little bit about the management. So we're going to start with the case. It's a 2-year-old male with history of sickle cell presenting with 2 days of decreased activity and fussiness. He's tachycardic 195, hypotensive 75/54. He's tachypnic 39, temperature is 99.8, O2 sat is 96. He looks sick, he's alert, he's got scleral icterus, his abdomen is tender in the left upper quadrant, and he has some splenomegaly there. His labs are significant for a white count of 15. His hemoglobin is 3. Platelets are 40,000. Electrolytes are for the most part normal. His creatinine is 1.6. He's got some AKI. Billy is 3. AST, ALT are a little elevated. His reticulocyte count is elevated. He's a little acidotic, and he's got lactate of 5.6. His chest x-ray shows no focal consolidations. So does anybody know what this patient is presenting with based on physical exam, labs, and just from what you know of sickle cell? Splenomegaly, low hemoglobin, anybody? Yeah, sequestration. So we'll get back to that. So just a quick overview, sickle cell disease is an autosomal recessive genetic disorder which causes a mutation in hemoglobin, causing it to sickle, polymerize, leading to the various sickle cell complications. Hemoglobin SS is the most severe form. There's also compound heterozygotes, so hemoglobin SC, hemoglobin S beta, and S beta plus, which is the least severe one. In a normal person, red blood cell lifespan is about 120 days, whereas in sickle cell, it can be from like 12 to 40 days. So these patients can become anemic much faster. These cells adhere to damaged vessels. They cause inflammation, platelet aggregation, they decrease blood flow, leading to sickle cell complications. Most commonly, sickle cell disease occurs in places where malaria occurs. So sickle cell carriers have a survival advantage in these areas, and it's thought that basically carrier cells get infected with the parasite, and then these cells selectively sickle and the body eliminates them faster, and so they have a less severe form of malaria. Basically in vitro studies have shown that that's probably what happens. Whereas patients with sickle cell disease develop more severe malaria, but the gene is propagated there because of the survival advantage. It is the most common genetic disease in the United States, affecting approximately 100,000 Americans. About 1 out of every 365 African-American births, a patient has sickle cell disease, compared to like 1 out of 16,000 Hispanic American births. So it's very common. It's also more prevalent since many advancements recently. So in the United States, every child is screened at birth for sickle cell disease. Penicillin prophylaxis has increased lifespan, hydroxyurea, chronic transfusions, and vaccinations against encapsulated organisms. But mortality is still very high. So average lifespan for males is about 42 years old, whereas for females, it's about 48 years old. About 18% of patients die from organ failure, most commonly renal failure, and 33% die during an acute crisis. So now we're going to talk about some of these sickle cell crises. So there are mostly like 4 main crises and then some other emergencies that we're going to talk about. So the first one is the most common, and it's the vaso-occlusive crisis. It comprises about 77% of visits per year in the pediatric population. Most are actually spontaneous. They don't have any triggers, but most common triggers are hypoxemia, infection, dehydration, menstruation, exertion, heat, emotional stress, anxiety, depression. Mechanism is inflammation, cell activation, which causes sickling, causes blockage of vessels, leading to ischemia, organ damage, and pain. So one thing to note is that these patients chronically have pain. They have pain often. And from a very young age, they are taught ways in how to manage their pain. So they might not look like a typical ED patient who's in pain, like let's say for the first time from like an acute appendicitis who's like writhing around. Some of these patients may look very comfortable. They may be texting, watching a video, and that's because they are taught like different coping mechanisms to kind of distract themselves from pain. So just because you see somebody who's like looks comfortable, is texting, but they're telling you they have 10 out of 10 pain, you should believe that they have the 10 out of 10 pain. Also, they commonly will have normal vital signs. So again, they won't be like the typical patient who's tachycardic, hypertensive. Usually they can be like have normal heart rate, normal blood pressure. So again, you just have to listen to your patient. So this vaso-occlusive crisis pain can last anywhere from 4 to 6 days. Most commonly, it's in the spine, long bones, and chest. Patients may have a low-grade temperature. And also another important thing is that there's no lab test that can tell us if somebody's in a vaso-occlusive crisis. So if this patient comes in and they're telling you that this pain is the same as they always have, and there's no red flag symptoms like no fever, no chills, then you can treat it as a simple vaso-occlusive crisis, no need to get any labs. You can give them pain medicine, reassess. But if they do have fever or chest pain, for example, you need to do more of a workup. So pain crisis is a diagnosis of exclusion. Dactylitis is a vaso-occlusive variant in infants and toddlers. About 40% of children less than 2 will develop dactylitis. It's one of the earliest clinical manifestations of sickle cell, and it's caused by ischemia and infarction of bone marrow in like the fingers, toes, hands, feet, because this is where hematopoiesis occurs in infancy, and then it moves to the central locations, and that's why patients have pain later on in the long bones. Patients who develop dactylitis less than 12 months of age have like about 3% increased risk of having 3 times more risk of having severe sickle cell disease, so you can warn parents about that. Preverbal kids can present with fussiness, crying, altered sleep, decreased feeding. Patients can be febrile. They'll have erythema, warmth, and tenderness of the hands, feet, fingers, and toes. This can be mistaken for, and you should try and rule out cellulitis, abscess, fracture, osteomyelitis, and septic arthritis in these patients, and it's kind of challenging to do so. There have been some studies trying to differentiate, trying to find ways to differentiate between osteomyelitis and dactylitis. In this study, about empiric antibiotics were given anyway because it's very hard to do so. So like 308 kids out of 358 got empiric antibiotics, but only 3 had osteomyelitis, and those 3 that did have significantly elevated CRP and white count. So Next crisis we're going to talk about is hemolytic crisis. This is increased hemolysis of the already fragile red blood cells, and the production of red blood cells by the bone marrow is unable to keep up with the destruction, which leads to anemia, which is defined by greater than 2 gram per deciliter drop in hemoglobin below baseline. This can be seen in vaso-occlusion and infection. Patient can present with fatigue, paleness, jaundice. Labs will show a low hemoglobin, high reticulocyte count, high bilirubin, high LDH. And then this can lead to jaundice, gallstones, and more complications. Aplastic crisis is an infection by parvovirus B19. It infects red blood cell precursors, causing severe anemia. Reticulocyte count, this is what distinguishes this crisis from the other one. So reticulocyte count is going to be very low, sometimes undetectable. And it causes severe anemia. These patients should be observed. It's mostly self-limited, and in a few days, their blood counts come back up, but you should monitor for need for transfusion. If hemoglobin is less than 5, or if they are severely symptomatic, these patients should get a simple transfusion. Sequestration crisis. So this is a sudden enlargement of the spleen, which is associated by a decrease in hemoglobin of at least 2 grams per deciliter. And in this case, you will see increase in reticulocytes because the body is trying to compensate for the decrease in hemoglobin. This can be the initial presentation of sickle cell in about 20% of patients. It's most common in kids 6 months to 5 years old because this is when they are still having splenic function before autosplenectomy. It can happen later on if patients are on chronic hydroxyurea therapy, chronic transfusions, if they have preserved splenic function. It has a very high mortality rate, so it's very important to identify this early and treat it as quickly as possible because mortality rate can be up to 44%. Death can occur within a few hours because the spleen can trap enough circulatory blood volume that it causes shock. So in this case, red blood cells, platelets pool within the spleen. They decrease blood flow, cause an acidic environment in there, and then basically cause a cycle of just further pooling, sickling, increased viscosity, and obstruction. Patients will present with fatigue, pallor, decreased activity. They'll have tachycardia, hypotension, so basically present in shock. On exam, you'll be able to palpate an increased size in the spleen. The hemoglobin will be decreased. You'll have decrease in platelets, reticulocytosis, and high bilirubin. There's no need for imaging to diagnose this. Usually spleen is palpable, and it's important for parents to do spleen exams at home. So usually the parents will know the baseline spleen size and will be able to tell you if it's enlarged or not. It's important to identify this early and treat. You're going to put in 2 large bore IVs, resuscitate with IV fluids until blood becomes available, and then start with simple blood transfusions. One complication with this that can arise if you do transfuse too much, you shouldn't transfuse greater than 8, but basically once the acute crisis is done, the spleen can actually release the blood cells back into the body. And so if you've transfused greater than 8, and then the spleen releases all those red blood cells, it can cause hyperviscosity, which can then lead to heart failure, stroke, like much more complications. So you want to be very conservative in transfusing and get hematology on board as well. Yeah.
Sorry, I was going to say, I think we actually had a case, or if you guys remember, like sometime in April 2020, there was actually a case that came in, and this kid actually came in with respiratory distress, and I think it was because he was so anemic that he was using his accessory muscles to try to help oxygenate. But the kind of dead giveaway that we got is once we were able to get blood on him, it looked like Kool-Aid. So Yeah, it was like really thin and pale and did not look like blood. So really, like as Khristina said, your goal is to provide isotonic or crystalloid fluid, just in case by giving blood you cause them to sequestrate even more, but calling hemonc early on and letting them know your suspicion, because I remember they specifically were like, you want to transfuse this amount, you don't want to go over this amount of blood that you're giving them. This kid ended up dying, but it happened very quickly. He coded within like 5 minutes.
Was that the twins?
Yeah.
Okay,
Yeah. So just be really, really cognizant. In the same way with hemolytic crisis, the thing that's going to trigger them the most is infection. I think the same thing is true for this kid because he went with a fever initially. So just be very, very careful if you have like a kid coming in around that age with sickle cell and they look terrible. Feel the spleen.
Yeah.
Yeah.
Okay, so next we have acute chest syndrome. So this is the second most common presentation to the ED, but it's the most common cause of death in pediatric sickle cell disease. Mortality of one single episode of acute chest is about 9%, which is equivalent to that of a STEMI. So patients who are hospitalized for other causes, like vaso-occlusive crisis, about 50% of them will develop acute chest syndrome while in the hospital. So it's very important to try and prevent this. We can do that in the ED by providing an incentive spirometer, make sure that they're not developing atelectasis, make sure we're not giving too much fluids, which can lead to pulmonary edema and can cause acute chest. Fever is a common presentation in acute chest, and cough. But diagnostic criteria is a new finding on chest x-ray with respiratory symptoms. Another thing, a way to diagnose, so chest x-ray versus ultrasound. There has been a lot of study in which one is more sensitive, which one's more specific. So actually ultrasound is a much better test to diagnose acute chest. It's about like 83% more sensitive and 100% specific for acute chest, whereas chest x-ray is only 17% sensitive and 50% specific. Abnormalities on ultrasound were present a day before they were present on chest x-ray as well. So on ultrasound, you're looking for B-lines, pleural effusions, absence of lung sliding, pleural thickening, air bronchograms. It's also important to consider CTA in patients who you may have a high suspicion for PE for, which these patients are at greater risk because they can be hypercoagulable. Patients with acute chest have very high risk of respiratory failure, and therefore almost all of them should be hospitalized. They should be hospitalized in a hospital that has an ICU. And so if in the future you work at a hospital that doesn't have ICU, you should probably transfer the patient while they are still stable, just in case they do decompensate, because they are prone to decompensate. Treatment for acute chest is aggressive pulmonary toilet, so chest percussion therapy, incentive spirometry. You want to keep oxygen saturation greater than 95%. Consider high flow if needed. You're going to give them antibiotics because it's essentially impossible to differentiate pneumonia from acute chest. So usually a cephalosporin and a macrolide for atypical coverage. If you're suspecting like bronchospasm, if the patient's asthmatic, nebs can help as well. And very important, pain management. So if a patient is in pain and they're not comfortable, they're not taking deep breaths, that can cause splinting, can further worsen acute chest by causing more atelectasis. You also want to avoid IV fluids in these patients because overhydrating can cause fluid overload, pulmonary edema, and can worsen acute chest. And if a patient is presenting with severe symptoms, or if they're worsening, if their oxygen requirement keeps going up, then they may need an exchange transfusion. Infection. So sickle cell patients are prone to infection because they're immunocompromised because of autosplenectomy. Early days, they had very high risk of sepsis and sepsis mortality due to pneumococcus encapsulated organisms like strep, H. flu, salmonella, Neisseria. Now with vaccines, penicillin prophylaxis, mortality has gone, like the rate of bacteremia is about 1%. Compared to like 11% in the past without penicillin prophylaxis and vaccines. Infection in sickle cell warrants a workup if the fever is 101 or greater. So fever of 101 in the ED or 101 measured at home, patients should get a full workup, including CBC, reticulocyte count, blood culture, lactate. They should be treated with a dose of ceftriaxone in the ER, and then their disposition kind of depends on like high risk, low risk criteria, which we'll go over. So low risk, high risk criteria, if kids are less than 2, if they've had bacteremia in the past, it's like an extensive list, but it's kind of self-explanatory. So if they've had bacteremia in the past, sepsis, history of splenic sequestration, they should be admitted. If you're going to discharge them, you want to make sure that they have reliable follow-up. You want to make sure that they have a hematologist that they can follow up. You have a good phone number for them. They're able to get to clinic or to the hospital the next day for the second dose of antibiotics. And some lab findings for low risk criteria. So if patients have a white count that's between 5 and 30,000, you can discharge them. If they don't have any chest x-ray findings, if they have a negative UA, if their reticulocyte count is less than 1% and hemoglobin greater than 5, then you can discharge them. Another sickle cell emergency is stroke. So patients with sickle cell disease have a 400 times greater risk of developing stroke than the general population. About 11% will have a stroke before they're 20 years old. Most common presenting symptom is hemiplegia. They can present with seizures, any type of neurodeficit. So any kid with sickle cell that presents with a neurodeficit is a stroke code. You're going to get labs, CT, they're going to be admitted for MRI. And treatment for stroke and sickle cell is exchange transfusion. It's been shown that exchange transfusion decreases the risk of developing a second stroke, which recurrence is very common. About 60 to 90% develop like recurrent strokes. Priapism is also common in sickle cell. So about 90% of boys less than 20 years old will develop priapism, which is defined by an erection that's greater than 4 hours, and it's unrelated to sexual stimulation. At 6 hours of priapism, basically there's irreversible tissue damage, which can lead to fibrosis and impotence. These priapisms are low flow priapisms, which basically cause compartment syndrome of the penis, causing permanent damage. And then management as analgesia, penile nerve block, blood drainage, and phenylephrine. You can use ketamine for conscious sedation for peds patients. Ketamine can also help cause detumescence. Hepatobiliary complications are common in sickle cell, more rare in children, more commonly in adults, but it does have a high mortality. For example, intrahepatic cholestasis can cause fulminant liver failure very quickly, leading to coagulopathy and encephalopathy. So very important to assess for as well. And just to mention a few others, so hemoglobin SC patients can develop ECAST, which is exertional collapse associated with sickle cell trait. It causes like 40 times increase in exercise-related deaths. Mechanism isn't exactly clear, but If you have an athlete who collapses and they're known to have hemoglobin SC, make sure you check a creatinine. They develop rhabdo, they're going to need aggressive fluids, and a way to differentiate ECAST from like a heat stroke, for example, during exercise. These patients will most likely have normal temperature. Their muscles will be very soft compared to like tight muscles in athletes who have like overexertion. And yeah, treatment is aggressive fluids. Renal medullary carcinoma is something to keep in mind as well. Usually happens like in adolescent, young adults, mean age is 21. It causes painless hematuria. So if you have a patient who is a sickle cell patient presenting with painless hematuria, they need a workup for malignancy. Most patients who present with painless hematuria, at that point, their disease is already disseminated and average survival is actually 15 weeks. So at that point, it's probably too late, but something to keep in mind. Traumatic hyphema is also an emergency in sickle cell. These patients have increased rates of rebleeding into the anterior chamber. The sickled cells can block the canal of Schlemm, which causes increase in intraocular pressure and can lead to acute angle closure glaucoma. So keeping all of those things in mind, if a patient presents with sickle cell and we want to figure out what exactly is going on, so we have to ask, when did the symptoms start? If they have a fever, you want to know, how was the temperature obtained? Was it a rectal temperature? Was it an oral temperature? Did they give Tylenol at home, which masks the fever in the ER? In their history, you want to know, are they on hydroxyurea? This medication can cause immunosuppression, make the patient at greater risk for infection. Are they on chronic transfusions, which could indicate that their sickle cell is more severe? Are they compliant with their penicillin prophylaxis? You have to make sure the child is vaccinated. Are they up to date on all the sickle cell specific vaccines? On physical exam, are they ill? Are they toxic appearing? What is their work of breathing? Are they tachypnic, retracting? You want to make sure you unclothe the kid and look at everything. So is there any evidence of, like, is there any redness, swelling anywhere, osteomyelitis, septic joint, things like that? Do they have any focal tenderness? So in our patient had an enlarged spleen and tenderness in the left upper quadrant. So for, again, for patients who are just presenting with simple vaso-occlusive crisis, no need for workup, but any other red flag symptoms, blood work, including CBC, CMP, retic, and anything else that'll, well, we'll talk about. So management-wise, so IV fluids. Most patients actually do not need to be given like boluses of IV fluids. If you're giving normal saline, it can cause metabolic, hyperchloremic metabolic acidosis, which can propagate further sickling and worsen their condition. So most patients just require maintenance fluids. If they're able to tolerate PO, they can actually just drink. But maintenance fluids with like D5, half NS, like hypotonic saline is thought to rehydrate red blood cells through osmosis. So better than just regular normal saline. So the goal for these patients is euvolemia. You don't want to bolus everybody fluids. Has to be kind of personalized to each patient. Supplemental oxygen, you want to make sure their oxygen saturation is above 95%. Antibiotic wise, these patients will get ceftriaxone, and then if you're concerned for pneumonia, the most common causes of pneumonia for sickle cell patients are atypical organisms, so mycoplasma, chlamydia, so they should also get a macrolide as well. Hydroxyurea, you're not going to start in the ER, but if a patient presents with vaso-occlusive crises very often, you can mention to the parents that they can follow up with a hematologist, ask about hydroxyurea, which is actually a great medication that helps prevent vaso-occlusive crises by increasing fetal hemoglobin and decreasing sickling. And transfusion and analgesia we'll talk about. So for pain management, sometimes people can think that sickle cell patients have greater risk of developing addiction, or there's higher addiction rates in sickle cell patients because they're chronically on opioid medications. According to the literature, that's not true. They actually have the same incidence, same risk of developing addiction as general population. So you should always treat their pain. If they're telling you they're in 10 out of 10 pain, then treat it accordingly. So this is just the CHOP algorithm of pain management in the ED for sickle cell. So if their pain is mild, you can give them PO medicine, reassess. If they're having moderate to severe pain, you can start with combination of things. So you can give IV opioids, IV Toradol. Each time you're giving a pain medicine, reassess them in 30 minutes. If they're still having severe pain, give 50% more of the medicine that you gave initially. So if you're giving 2 of Dilaudid, reassess in 30 minutes, give 1 if they're still in a lot of pain. Then reassess again in 30 minutes, give 0.5 if they're still in a lot of pain. If you're giving multiple IV doses, so like greater than 3 IV doses, they're still having persistent pain, you're probably going to have to admit this patient for intractable pain. One thing that we can do is ketamine for pain now. If a patient isn't responding to opioids, so 0.3 mg per kg of ketamine can be helpful in these patients as well. Apparently, we also have PCA pumps on the floor, so patients can control that themselves by like pressing a button, and they'll get delivered the pain medicine, and there's like up to a certain limit that they can get. Also, if the patient has no IV access, you can do intranasal fentanyl in the ER in the meantime while you're trying to get IV access for more stronger pain meds. And transfusion. So there are 2 types of transfusion for sickle cell. One is just a simple transfusion like everybody gets, and the other is an exchange transfusion. So simple transfusion you can use if a patient is symptomatically anemic, but exchange transfusion is reserved for severe cases, like for example, stroke, patients who have acute chest and aren't improving or are rapidly deteriorating. In an exchange transfusion, you have to put in a central line. These patients are going to get admitted to the ICU. Hematology has to be involved because you have to figure out how much volume to transfuse, which you can use this formula on MD Calc to do. And in this case, the patient's blood is basically it's kind of like a dialysis type thing. So their blood is getting taken out, their red blood cells are getting filtered out, and then they are getting like normal red blood cells. So you're trying to decrease the percent of hemoglobin S to decrease like hyperviscosity and just decrease sickling. And just some new controversial treatments for sickle cell. Magnesium sulfate is thought to increase nitric oxide, which can lead to vasodilation. Basically, studies have been done. PCARN did a study in 2013, which showed actually no difference. So mag sulfate doesn't really help. Corticosteroids, there was a Cochrane review which showed that corticosteroids do help in vaso-occlusive crisis, but they also cause rebound pain. And so most likely should not be given. If you do give it, you should speak to the hematologist before you do. Nitric oxide is used in some countries. So in France, actually, if somebody presents with a vaso-occlusive crisis, first-line therapy is inhaled like 50% oxygen, 50% nitric oxide. Again, it's thought to cause vasodilation, helping with pain, because in vaso-occlusive crisis, you have vasoconstriction, blockage of vessels. but studies have shown no difference. Ketamine, we already spoke about, great to use, and then gene therapy. So there's actually a study being done in Cleveland Clinic, which started in May. They're starting with adults, and they're doing like this CRISPR gene editing thing to kind of cure sickle cell. So that's something that might be new and promising, but we don't know yet. So yeah, back to our patient who had acute splenic sequestration. Patient was admitted to the ICU. He was transfused 2 units of blood, ended up getting better and being discharged. So that is basically it. Yeah. Does anybody have any questions? Yes.
That was great. Really great explanation of everything. What I wanted to emphasize, especially with the adult patients who aren't as cute and, as sick looking as the little ones, and we have a lot of adult patients, and it's important. One of the therapies that is very important is empathy. And as you pointed out very early in your lecture, is they do have a terrible disease with a lot of complications, and they do have decreased lifespan. Even now with our antibiotics and transfusions, and hydroxyurea, they all have decreased lifespan, and they don't have a nice life. And especially some of the adults who need very strong medications to keep going, at least, and who come all the time to the ER, and they're screaming, or they're asking for things, or they don't seem in pain, and we kind of, I think a lot of us, even me sometimes, look at them as maybe bothering us or just want to get rid of them. But it's important, as you pointed out, to remember they have a terrible disease, that we don't have at this point a cure for this disease. And one of the best things we can do is to be empathetic and nice to them and treat their pain, which we can do.
Two comments. Just one, remember that the mixed genotypes for sickle cell can present, atypically. Sometimes they can have no complications, and sometimes they can have complications at different ages than usual. So just be vigilant with that. And then just a very important point that Khristina brought up is about stroke care. So not as a stroke patient, but it's common in these patients. You're not going to get TPA. You're going to exchange transfusion. It's still called stroke code and everything, but just remember that if you're the ED doc, you're the generalist, you know probably more about sickle cell stroke than maybe the neurologist will, so that will be a different treatment. If I could maybe kick it to the PEM folks, I feel like a very common thing that EM docs might take care of in the community, and maybe not at a children's hospital or have a pediatric ED, will be sickle cell fever. So how do you guys think about that when you can't maybe call up the peds hematologist and say, hey, these are the labs, what do you want me to do?
Your question is how to treat them?
Yeah, like I know Khristina kind of put up like a low risk, middle risk in terms of putting in an algorithm, but how do you guys approach thinking about that? If they look okay in the lab, okay, they can go home and get Ceftriaxone, or is there any more nuances for that?
So I think there's a couple of things in terms of particularly like what makes kids high risk. So a couple of things are going to be temperature over 40, a drop in the hemoglobin more than 2 grams per deciliter, anything that was obviously, I mean, I'll tell you guys that anything that doesn't look well should be admitted, but those are sort of the nuances. The other thing is, feeling out the family for whether they're going to come back, because they have to come back for a second dose of Ceftriaxone. So if you get the sense that maybe they don't have an understanding of that they have to come back, or you're meeting some resistance that you think that this kid may not be back for that second dose, I think those are all for me kind of reasons for automatic admission.
On the flip side, that patient knowing that the family is going to come back, the child has to take an exam in the morning, they want to participate in something, so we can't be obstructed in their life. So if they're looking well, they've got sickle cell, they can come in with fever, but they've recovered enough where you can send them home. Just give them really strict instructions back. And you have to kind of trust them, but also even in our community, I've had many mothers say, all right, I'll leave tomorrow because I'm here tomorrow and I'll see you tomorrow. I'll take your phone number and I'll call them.
The other thing is, I could have been a downstatement a little bit, but at county, you guys could do an audio visit follow-up in the event that you're concerned they may not come back, so we can call them as a reminder. But yeah, the temperature over 40 and the drop in the hemoglobin of more than 2 are sort of automatic criteria.
Yeah.
Just to piggyback on her, I think what you're talking about, the criteria of mild, moderate, look at, I would add, like you said, WBC, if you're not seeing enough of that, you need to be book-wise when you're managing that, because you have very strict criteria to look at. So if the count is less than 5 or more than 30, drop of hemoglobin of less than 2, a prior strep pneumosepsis is there, platelet count of less than 100,000. Those are like defined criteria that have been shown to increase mortality. So I like, if you work at me at UHB, if you see a viewer with sickle cell, I will just print this out and give it to you to look at and say, these are the criteria that they meet. Any of them, we will admit them anyway. So I think that is something to keep handy on. Would be the only things I would look at.
The last thing I was going to say is we had a 9-month-old who actually looked really well, had a fever. I just remember him coming back for the second dose of antibiotics, but like this kid was less than 2 years old, but looked really well appearing, versus we had a kid who was 2 years of age. And I'm not sure, the kid got admitted after I was done, but the kid also looked really well appearing. So I think it depends on your comfort. But the other thing I was going to say is that Tan had mentioned at Bellevue, these kids will show up for their second dose of ceftriaxone in the hemo clinic. So they'll show up like the day after, or they'll have a walk-in where they can come in, someone can see them and may not even give them the second dose. So it really depends on your institution's resources, obviously, but the whole, I think, like, to back up Dr. Tijani's point, there are definitely guidelines. It's just a matter of like what you feel comfortable with and what the family feels comfortable with.
Sorry, one more comment.
Yeah.
Another question always comes up if you're working there. The ED says, parents come and tell you, but I had a reaction to ceftriaxone. It's very rare.
Oh, yeah.
It can be fatal. It causes severe hemolytic bleeding with ceftriaxone. So what if I'm allergic to ceftriaxone? Then are you going to keep me in the hospital? You're going to put me on PO third generation and send me home?
No, I think you
How
can.
does my adult ED colleagues manage that? Have they ever come across a patient like that?
You can get chloroform.
Yes, please go ahead.
So again, if they're allergic to ceftriaxone and I'm worried about it, I mean, there is very little crossover. It's less than 5%, probably close to 1% between penicillin and ceftriaxone. So they say they're allergic to pen unless it's anaphylaxis, you can still use ceftriaxone. But if they're allergic to ceftriaxone, to any cephalosporin, then for sure I wouldn't use ceftriaxone. And you can use, in an adult, you can use the quinolone, and the one I like is levofloxacin. It has good atypical coverage. It has, very good pneumococcus coverage. And so that's what I'll use. And that's what the criteria of the ATS, it's the guidelines are for pneumonia. Obviously if it's complicated because they have an infected line or something where you think it's staph or something else, and they have to use things like example.
So generally, we're talking about well-appearing sickle cell is acute. If you're allergic to ceftriaxone, the problem becomes is that your blood culture will take 24 hours to come back. And the reason of giving ceftriaxone is because it's good to stay in your system for 18 to 24 hours. Now, what am I going to be left with? Like you said, the next choice of drug is ampicillin, but that's every 6 hours. So are on the side of admitting them rather than sending them home in the pediatric population, at least think that way. Of course, the conversation with the hematologist and if they have some other reasoning, but most of the time, if you're allergic to ceftriaxone and I have to give you a medication that is every 6 hours, I are on side of admission rather than sending you home on a PO for 6 hours.
Yeah, I mean, I would tend also anyway to admit an adult who had significant fever and with an infection anyway with sickle cell. They just don't do as well because they're by then asplenic and they don't. But what's nice about the respiratory quinolone, particularly levofloxacin, is it's once a day also. And an adult in an adult for pneumonia, you do 750. And that lasts a whole day. So that's an alternative in an adult. They're not using quinolones usually in kids, right? So it is a difference. I agree with you.